All right, welcome everyone back to another virtual shadowing session with Hearts for Health. Today we're going to start our week with Dr. Chung. He's a retired Army colonel, and we're going to be hearing about the field of critical care medicine. We're also going to be hearing about his new introduction into a medical technology company, into a new role. He used to be in military medicine, but he's transitioning into a new role. We're going to hear more about that from Dr. Chung. As a quick few reminders for those who are listening in, especially those who are new to virtual shadowing, we have a Q&A at the end of the session. So let's say you have any questions for Dr. Chung, please type them in the chat and we'll get around to them. At the very end, we're going to be reading them in order. So it's really first come, first serve in terms of going around through questions. But like I said, if you have any questions, let us know through the chat. If you'd like to stay updated with future shadowing sessions, because we have many actually that we've been doing almost 50 now, and we're going to be continuing that through this semester. The spring semester hopefully is the plan. So just to stay tuned with that, you can either follow us on Instagram or join us on our listserv by either subscribing at the bottom of our webpage, where we have a subscription form. Just enter in your name, your email, you'll be good to go. Or you can email us at shadowing.h4h@gmail.com and ask to be added to the listserv, and we'll manually add you in from there. If you have any questions outside of that, let us know through email. We're always happy to answer any questions, just help you out generally. We do have more than just a shadowing program. So let's say you have any questions for our volunteering programs or our mentorship program, please let us know also through email. We're happy to answer any questions. With that said, though, Dr. Chung, feel free to take it away.
All right. Thank you, Michael, very much for that introduction, and just congratulations on a very remarkably successful program that you've put on over the last year, 50 speakers, and I've seen the list. It's really amazing that you've been able to do what you've been able to do. And this is quite a program that you're offering for a lot of folks out there that are interested in health. So hello, everybody. My name is Kevin Chung. I am a critical care doctor trained in internal medicine. And today what I'm going to do is talk about my path through medicine in the military and how I got there, and sort of talk about what motivates me as a physician now in the medical technology industry. Okay. These are my financial disclosures. I am primarily employed by C-Star Medical now as the Chief Medical Officer, but I also advise for multiple other companies, 2 nonprofits, and 2 for-profit companies that you see here listed. So I'll take you all the way back to where I was born. This is important because I was not born in the United States. I was born in South Korea in 1972. At the age of 3, my parents moved our entire family to Paris, of all places. So we lived there for about 5 years. And we landed in New Jersey when I was 8 years old. So imagine, as a 3rd grader, I didn't know any English. I spoke French fluently, and my first language was Korean. And so I learned English actually through a French tutor who spoke French fluently, obviously, and taught me English, her native language. And so that's really how I got started. And we moved my 6th grade year, middle school, to Northern Virginia. And I had an opportunity in Northern Virginia to apply to the school Thomas Jefferson. At that time, it was a very new magnet school, and now it's pretty well known in the region and nationally. But I was very fortunate to be able to be in an area where I was able to attend this magnet school, very, very good education. And it was there that I started thinking about the military. Ever since, given my, the fact that my parents were immigrants and the fact that I came to this country pretty much really as a result of my parents being here, I wanted to be American. I wanted to assimilate, be like the other kids. That's sort of natural as a kid. And so, while going through high school, I was very, very much obsessed with trying to fit in as much as possible, like everybody else. And so I felt the best way as a immigrant Asian American kid to fit in and be American, quote unquote, was to go into the military. And so that's what I did. I joined, I applied to West Point and was able to get in. I was fortunate enough to get a nomination as well as an acceptance. And I entered the United States Military Academy back in 1991. And it was there that as I was going through school, I sort of first thought about medicine as a profession. Not a lot of people know this, but even in the academies, about 2% of each graduating class have an opportunity to go to medical school through a program specific to each of the academies. And so I was able to apply for that program and apply to Georgetown, and I was fortunate enough to get in, and that's how I entered medicine through the military. When you go this path, there's something called a health professions scholarship, which basically provides, it's like ROTC, where through medical school, you have your entire tuition paid for and you get books, and you don't get housing, but you do get a stipend. So you're able to at least pay for some of your expenses. And so that's what I was able to do, through undergrad, go directly to medicine at Georgetown and have medical school paid for. And so nothing is really free in this world. So, but what I mean by it being paid for is that it was essentially a trade in return for the tuition. I had to serve in the military, and I was happy to do that given the fact that I went to West Point knowing that I would be in the military anyway. So after medical school, I got sent down to Eisenhower Army Medical Center, where I began my internal medicine training. This is in Augusta, Georgia, or Fort Gordon. And it was during that time that 9/11 happened. I was a third-year resident, and I remember this distinctly. I was doing a gastroenterology rotation, and somebody in the waiting room there was a TV there, and they came out and said, "You need to see this." And we watched on the TV with horror and observed what was happening, and we all realized that our lives, all of us in the residency program, had changed. It was at that time that I decided to do critical care as a subspecialty of internal medicine. Prior to that, I was thinking, contemplating going into cardiology or GI, and all those, both of those are very, very nice specialties. But when this happened, at least for me, I wanted to do critical care so that I could, train in the specialty that could be the most helpful in this situation. I knew that we were going into many regions of the world where we would be receiving lots of combat casualties. And so that's what I wanted to do, critical care. And so when I graduated residency, that was followed by fellowship. So in general, medical school is not the end of training, believe it or not, as many of you probably know. There's a 3 to 5, sometimes 6-year residency program. For me, it was a 3-year program, and I did an additional chief year, so a total of 4 years. And then after that, I did 2 additional years of fellowship training. This is the old Walter Reed Army Medical Center, before the Walter Reed National Military Medical Center that exists today in Bethesda. This was in DC down Georgia Avenue. And so this is where I did my fellowship training in critical care. And in 2003, unfortunately, that's when we began receiving wave after wave of combat casualties from the Middle East. And I had an opportunity to take care of, unfortunately, but also from a training standpoint, it was something that shaped me, an experience that shaped me into the doctor that I was meant to be. That experience taking care of combat casualties was really, really crucial in my understanding of what I needed to do. And so immediately after training, my fellowship training, I was assigned to San Antonio, where there was a burn center there. Burn Center is the U.S. Army Burn Center under the Institute of Surgical Research. And you probably see this glass building. The entire 4th floor is the Burn Center. So that's where I was assigned. And I spent 12 years in the burn center and an additional 2 years at the main hospital, Brooke Army Medical Center, where I was chief of medicine. And during those 2 years, I really enjoyed dealing with the residents and the trainees, as well as interacting with students from the Uniformed Services University, which is the DoD's medical school in Bethesda, Maryland. This is a very unique medical school. It is a fully accredited U.S. medical school where you graduate with a MD degree. The unique thing about this school is that it's completely paid for, but you also get a full salary as a second lieutenant, which is very unique. And so you get paid to go to medical school. Obviously, like I said, nothing is free. You pay with service back to the nation as a military medical officer, but it is a very unique experience and a medical school you should look into. So the medical school you could see is in the back right-hand corner there. But you can see that if you look at an aerial view, this is Walter Reed National Military Medical Center. So this essentially is the hospital that congressmen and women, senators, and vice president, dignitaries go to for their care in the setting of an emergency. So this is Walter Reed. And so you can see that the Uniformed Services University is co-located with Walter Reed. So this is where I was for about 4 years. I was happy as a clam being chair of medicine and loving my job. But then an opportunity came that I just could not refuse. It was right along the path of what I was passionate about. And I'll talk about that a little bit later in a field that that was potentially, groundbreaking and a potential for breakthrough technologies to emerge. And so it was an opportunity for me to advance medicine in the way that I was not able to do within the scope of DoD. This technology, this company really is trying to address the final common pathway that results in organ failure and death. Anytime you have an insult, whether it's surgery, trauma, or you get infected from bacteria or virus, that triggers a cytokine storm that is rooted in effector cells. So neutrophils and monocytes are responsible for that. Well, the technology addresses that source. And so that was very intriguing to me, and something that I think is a breakthrough type of technology that I have an opportunity to bring to market and put in the hands of clinicians that are taking care of very sick patients. So this is my company right now. Eric Schlorf is the CEO, and he's the one that recruited me to join the company in July. So as of July, I am the Chief Medical Officer of C-Star Medical. So Walter Reed Army Medical Center here, what I'm going to do is talk and tell you some stories about patients I've taken care of and what that has resulted in terms of advances in care and other things that came to be as a result of these patients. As I entered my first day of fellowship in critical care, I was in the Walter Reed Surgical Intensive Care Unit, and the entire unit was full of combat casualties. So service members anywhere from the age of 18, 19 to some of them in the 40s were injured in the Middle East, and they were taken care of, many of them at Walter Reed. And this is one of the first patients that I took care of. I could say his name because it's available widely, and this story has been told over and over again. Hilario Bermanis. He was manning a weapons depot in Iraq when an RPG, a rocket-propelled grenade, got fired at his position and basically went through his arm and both his legs. He lost those 3 limbs and suffered what's something called rhabdomyolysis, which is a condition where your muscles essentially die, the cells of your muscles essentially die, and contents spill into your bloodstream, causing a toxic effect and causing your organs to shut down. He had not only renal failure as a result, but bad ARDS, or acute respiratory distress syndrome, something that a lot of people, you probably heard a lot of people talk about within the setting of COVID, but In this situation, it was rhabdomyolysis causing multiple organ failure, to include the lung, ARDS, and the kidneys, acute kidney injury. And so we had him on life support for quite some time in the ICU. And you can see him recovering. He was out of the ICU by the time this picture was taken. And within 3 months, he was fit for prosthetics and essentially was the beneficiary of some very, very advanced prosthetics. You can see one of them here. Within 4 months, he was actually walking with these myoelectric prosthetics, leg prosthetics that allowed him to walk, sensing the muscular twitches in his hips, which is just amazing. So at that time, there was a DARPA program. DARPA, you may or may not know, is a governmental agency that was established in 1958 when we were surprised by the Soviets at that time by the launch of Sputnik. Congress basically created this governmental agency in order for us as a nation never to be surprised technologically ever again. So think about this. Congress basically created this organization, and a lot of funds flowed through this organization so that we could remain technologically advanced. The internet, seed funding for the internet originated in DARPA. It was originally called DARPANet. Interesting fact. And so back then, when we were getting a lot of patients coming in with multiple limbs or single limb amputation, and that was really the signature of the war. And so one of the program managers, his name is Jeff Ling, said, why can't, and we all grew up in the age of Star Wars and Luke Skywalker and you know, the third episode where Luke Skywalker returns, the Return of the Jedi, where he has a prosthetic and it looks like a regular hand. And he said, well, why can't we have that? And so the DARPA program decided to put a lot of money into this, and they created a program dedicated towards improving prosthetics, to the point where they were able to, with this program, innovate and create a prosthetic that was controlled by the brain. Just amazing technology. And so the Mobius Bionics Luke arm was born, and this is an upper limb prosthetic that is controlled, and it's just very highly functional and something that is a major advance in prosthetic technology. This is Alex Smith. Many of you may have seen him play a few years ago for a variety of different teams. He started with the Chiefs, but when he was with the Washington football team at that time, he suffered a horrendous leg injury, comminuted open fracture of his right leg, and he thought he was going to lose it. And here you can see him rehabbing after multiple reconstructive surgeries. He had a bad infection, and he actually had a free flap, which means that tons of exposed bone and tendon. And you can see Joe Alderete in the back here. He's just a phenomenal orthopedic surgeon who helped him recover, Alex Smith recover. And this is another advance. You see that brace there. That's called an IDEO brace. And that was invented in the military to help special operators, so special forces, Navy SEALs, get back to duty after a limb that got disabled. And so there are a lot of soldiers and sailors and airmen who have been injured with comminuted fractures of the lower extremity that resulted in limb salvage procedures that back in the day, you would basically be relegated to walking with, a cane or anything like that. There wasn't a prosthetic for patients who had limb salvage, really not a lot of options. Here you can see that this brace, he went back to playing. This is a remarkable comeback story, and it was the result of many innovations that occurred through the military taking care of combat casualties. And so this is a wide view picture of Brooke Army Medical Center in San Antonio, again, where I spent 13 years of my career. And I sort of talked about briefly the U.S. Army Burn Center. And when I started there July of 2005. That fall, lots of burn patients were coming through the burn center. And this is the first group of burn patients that came in. In this incident, a squad of folks were in this vehicle called the Bradley Fighting Vehicle. And the vehicle hit a explosive device that was set off on the road. And one of the members, I'll show you a picture, Alwyn Cash, was able to get out. He was actually the platoon sergeant. He was able to get out through the hatch on the top and look back and saw that the vehicle had burst into flames. He was safely out, but his squad mates were stuck in the vehicle. And so what does he do? He does what any service member who loves the people that he's working with does. He ran back into the vehicle to try to save them. He was the most severely burned. Very, very tough situation. And 6 of the people that were trapped inside were burned very severely. And they were basically evacuated globally from Iraq to another hospital in Iraq, to Germany, all the way to San Antonio. And as a result of us being relatively new in the care of combat casualties, specifically burns, as a community, military medical community, we did not have a lot of knowledge that of taking care of burn patients. And so really, it was very early on. There was not a lot of knowledge in the theater of operations or Iraq in the combat support hospitals. Some, but not a lot. And also on top of that, there was not any documentation that occurred in a consistent basis. And nobody, when you did a handoff from one combat support hospital to another, to the flight team, to launch stool, there were 4 handoffs right there. Nobody knew from handoff to handoff what had happened previously. And so at that time, we created something called a burn flow sheet that helped us document. We created something called a clinical practice guideline that helped us standardize care in theater. And we did this in a couple of weeks. And over time, we basically put this into a decision support algorithm that helped basically guide a burn resuscitation. Somebody who's severely burned, they get lots of fluids early on in the first 48 hours. And this decision support algorithm helped guide the resuscitation. And even nurses and docs who were not familiar with burn care could now resuscitate successfully these patients. And so this technology, we patented it, and it was licensed to a company. And now it's available via an app on the iPad. And about 12% of all the burn resuscitations in the country occur with this decision support algorithm in the background that aids in the resuscitation. And it was even deployed in Ukraine, believe it or not. And so Alwyn Cash, who later received the Medal of Honor, was not helped by this device because it was developed as a result of his death. At that time, the clinicians and all of us did not have all the tools that we needed to take care of him. But I can guarantee you that he inspired the innovation that has helped a number of people. That was his legacy. And so moving on, I was deployed in 2008 to Baghdad. This is Baghdad ER, the main combat support hospital in the quote unquote green zone in Iraq, in Baghdad. There was a 5-mile radius basically a base within Baghdad that they called the green zone. I don't know why they named it the green zone, because it wasn't really green and it wasn't that safe. But anyway, so the hospital was there, and there was a patient. This is a tough story to tell. That was there, who was 20 years old. He was a private first class. He had gone out on a meeting, a tribal meeting with one of the elders with his battalion commander. And they had a meeting with the town chief, and it seemed everything was going okay until they came out. The translator didn't like what he heard. The translator turned his weapon towards the battalion commander, and this kid who's in the bed there jumped in front of his battalion commander and took all the bullets for him. A very, very tough situation. The battalion commander didn't have a scratch. He had 8 bullet wounds. And the reason I tell this story is, number one, it's just a tough story to tell. We were all emotionally very impacted by this. But clinically, we could not stop his bleeding. And it was before we were just starting to adopt a different way of transfusing trauma patients. And we had just ordered whole blood, but our techniques were just evolving, and we were not at a point where we were giving whole blood right off the bat. He did not get whole blood. He got component therapy. And prior to us over time evolving into balanced component therapy, so traditionally blood is given with just packed cells, just red blood cells, fresh frozen plasma, which has proteins that help with clotting, and platelets, and then fibrinogen. So they're all separated into these 4 components. Well, if a patient who's bleeding, if they need to clot, you need all those components. But the standard of care was just to give the red blood cells. That doesn't make a lot of sense, does it? Because you need those clotting factors, you need platelets, you need fibrinogen. That basically, composes of, if you combine them all together, that's whole blood. Well, that concept was not something that had been widely adopted at that point. Now it is, but as a result of people like him, this patient, this became something that over time evolved to standard of care. And now whole blood is really the way to go in trauma, and that's something that's being adopted widely. There was another technology that came from the combat operations in wartime just recently. This is called the ROBOA, retrograde intra-aortic obstruction. It's a balloon. And basically it goes into the aorta, and you can blow up that balloon and basically occlude the aorta and get bleeding under control. And so this is a big advance that occurred as a result of combat operations. And then TXA is a protein that can be administered that helps blood clot. All these things are now standard of care as a result of the lessons we learned taking care of multiple combat casualties. And you may have seen posters like this all over the country where you don't have to be at war to deal with combat casualties or to deal with massive casualties, as you've seen in the news, unfortunately, over the last decade. It could be an elementary school or a high school or at the airport or a concert. But this is a national campaign where we're teaching bystanders how to stop bleeding when you're encountering traumatic events. So these are tourniquets that can be applied, and now, along with something called AEDs, which are basically defibrillators. We have these kits that you're probably used to seeing in hospitals, and now in public places you'll see these all over the place. Stop the bleed. And these kits have tourniquets, they have gloves, they have shears, they have these bandages that are combat gauze, they're clotting gauze. So basically gauze with clotting substances in it, all things that were due to lessons learned and advances in trauma care. So one of the patients that came with Alwyn Cash, the guy that ran back into the burning vehicle, was Darren Howe. Darren Howe was the 6 out of 6 service members who were wounded in that same incident. Unfortunately, all 6 of them died. Just heartbreaking. Darren, was the last one to die in a 3-week period. He was somebody that developed renal failure. And at that time, although we had dialysis capability, we did not have a specific dialysis capability that allowed for renal replacement or dialysis in the setting of shock. And that's this condition that he was in. He needed something called continuous renal replacement therapy, and that was just not available. And so as a result of Darren's death, we were motivated to start a CRT, or continuous renal replacement therapy program. And it was wildly successful. Lots of burn patients were treated, and we demonstrated that it saved lives. We were able to extend this capability to the entire hospital. That then bled into, this is a patient in Afghanistan being treated with a device called Next Stage, which basically does CRT, or continuous renal replacement therapy. And we were even able to get this technology on the plane to stabilize patients while they were being evacuated across Europe and across the Atlantic to the United States. And so lots of advances. And this is one of those cases. In October, recently, about 3 years ago, there was a patient who was doing a regular patrol in Afghanistan, and shrapnel, a bomb exploded, and shrapnel hit his belt. Unfortunately, in his waist belt, there was a grenade, and the grenade exploded. And so he had a really, really bad injury that resulted in need for evacuation. He got over 100 units of blood. He got Reboa, and the balloon occlusion that I talked about. And as a result, had rhabdomyolysis, that condition that causes organ failure everywhere, basically. And so, although he did not need lung support, he was on the ventilator. He was okay on that. He needed renal replacement therapy, and they basically were able to treat him across on a plane in the middle of the Atlantic, continuously on renal replacement therapy all the way to San Antonio, with one mid-air refueling mission. That's just incredible. Over around 2,000 miles of evacuation continuously for this patient, and he actually survived. This is Jack Valentine. So Jack Valentine was stationed in the Pacific. He was on the USS Frank Cable, which is a submarine tender. So basically a ship that is in support of a submarine. And so he was involved in a unfortunate incident where he was working in a steam room, and a steam pipe exploded, and 1,200 degree steam just filled the room, and he inhaled most of it. So he had really, really bad ARDS, or acute respiratory distress syndrome. And the reason I tell this story, and he ended up not doing well, we didn't have something called ECMO at the time at our hospital. He ended up dying, and his case made us realize that our standard of care was not enough. We needed more tools, because he could have lived if we had this tool available called ECMO. And so his death inspired us to set up an ECMO program at Brooke Army Medical Center. And so that's what we did. We created this program over a couple of years. There's a long history of ECMO and technological advances that have occurred in ECMO. The first case in like the 1970s, but then huge advancements in care, not generally adopted until the late 2009. And here's a setup where you can see somebody getting ECMO with renal replacement therapy. So this is multi-organ therapy. So we're replacing not only the lung, we're bypassing the lung, taking blood outside the body, putting oxygen in it, taking carbon dioxide out, basically the function of the lung, putting it back into the patient, and doing the same sort of thing, and cleaning the blood out, replacing the kidney. And so we're replacing the lung and the kidney at the same time with this entire setup. And so this setup has really gotten more compact, and lots of technological advances here. And over time, the hospital, Brooke Army Medical Center, gained recognition nationally as a ECMO program. And so, his death, standard of care was not sufficient. We needed more tools, but I can guarantee you he inspired, a decade of innovation at our hospital and elsewhere. And his legacy is that he's helped a lot of different other service members and other patients, especially through COVID. A lot of patients needed ECMO through COVID, non-service members, and he's the guy that inspired it all. And so COVID happened, and I was, at Walter Reed practicing. It was my ICU week. It just so happened that my first ICU week back was the week that we started getting COVID patients in March of 2020. And I just so happened to have been part of a DARPA program called Dialysis-Like Therapeutics. And we had a couple of patients that were very, very sick. And out of this DARPA program came a number of different companies. One of them was Xterra Medical, and they had a filter or hemofilter, that cartridge that basically removed active virus from the bloodstream. And so we decided to, through the expanded access pathway through the FDA, it's an emergency use kind of thing, we were able to treat a number of patients, and that basically launched an entire program called the Purify program. And the reason I tell this story is that was a major advance that occurred as a result of us being desperate. Again, this wasn't wartime. This was a global pandemic. We had no treatment options. Standard of care was not enough again. And I can tell you, over the last 3 years, taking care of COVID patients, it felt a lot like when I took care of patients during combat operations, whether it was in the burn unit or a combat support hospital. Just everybody just focused singularly on the mission and doing everything they can to contribute, lots of teamwork, and also barriers that are just taken down for the sake of innovation and people being allowed to try things because we didn't have any other option, like the technology that Xterra brought, and many others, and we were able to advance this type of technology. And this is where selective cytopheretic device, which is manufactured by C-Star, the company that I work for, this is one of the devices that really emerged out of the COVID pandemic as something very promising. And one of the things I'm going to do is with the company is bring it, help bring it to market by showing the FDA that it's safe and that it's efficacious. And the only way to do that is through a pivotal trial or randomized controlled trial. And so I'm spending a lot of time now going around the country recruiting sites. And so that's really my job right now, to try to bring in exciting technology to the marketplace to put in the hands of clinicians who are taking care of very, very sick patients. So that's really all the stories I'm going to tell. And I don't know if, let's see, I'm going to stop sharing here. And I'm happy to take any questions. I know that was a little bit quicker than you anticipated, but I wanted to leave time for questions.
Absolutely. Well, first of all, thank you so much, Dr. Chung, for all of those stories. Actually, our first question has to do with them. A student asking, how do you cope with those harder cases? You mentioned the translator threatening or actually shooting the patient, and they hopped in the way of the personnel to save their lives. So obviously that's hard, and that's just one of many that you mentioned just there within the presentation. How do you take that in? Another thing, just to tag along with that, is have you faced any burnout associated with these challenging cases?
Yeah, so those are two great questions. So let me, I'm going to write this down so I don't forget. So the first question, how do you cope? So I can tell you, as an intensivist, when you're facing something as a human being you should not be facing, disfigurement, burns, somebody bleeding to death, just emotionally charged situation like that. First and foremost, you have to disassociate yourself. And it's very hard to do that. But in the thick of things, when things are going on, you can't be emotionally vested, and you can't, you can't be, you got to disassociate mentally, or else you can't do your job. So the way we all do this is we focus on the mission, we focus on the job at hand. and try to block out everything else. You're going to do this. I'm going to do this, A, B, C, and D. So you focus on what you need to do at that time. And the way you get there is through training, repetition, doing it over and over again so that it becomes natural, so that when you're stressed, you're doing things and you're sort of on autopilot and you're mentally disassociated. Okay, so that's the only way to get through a situation like that. You almost have to have this out-of-body experience and let your body go on autopilot. I mean, you just have to do it because you're the only one. And you know, obviously you have a team of folks and they're all doing the same thing. But then you got to deal with it because it's emotionally traumatic. And so that situation where that service member, you know, took the rounds for his boss, you know, we all cried. And there was a period where I just, I couldn't, you know, every time we had a service member die, we did something called an angel flight, and where we take the remains, everybody lines the hallway, and the body, you know, the remains are taken through and everybody salutes. And me personally, I couldn't attend that ceremony. I just emotionally did not have enough in the tank. And so you have to know when to take a break and separate yourself from emotional trauma. And so, you know, I hope that helps answer that question. Disassociate, it happens naturally just because as a professional, you just need to get your job done. And so that just happens sometimes naturally, but at some point you got to deal with it. Have I ever been burned out? Heck yeah. And so, you know, the first 3 years that I was assigned in the burn unit, I was pretty much there 24/7, 365. I took 10 days off total. Did I want to do that? No. I had three young kids under 5. It just, I had to. We had to because these are young kids that were coming in, and there was not a day where they weren't coming in, you know? And so I felt an obligation as an intensivist to be there. I was the only medical intensivist. We had surgeons and trauma surgeons and burn surgeons. We had a team, but I think everybody came in. And so I just remember those 3 years being just, you know, in retrospect, I was burned out. During that time, I just was completely devoted to the mission, and I, you know, forced myself and wanted to be there, but also just mentally, I was just in it. And I didn't realize until afterwards, oh, that's burnout. You know, just having very little patience, not, you know, not enjoying things as much as I should, not taking time away from myself, not balancing. And so, believe it or not, when I got deployed, even though I experienced, you know, emotionally charged cases like I just described, that was a break for me from the burn unit. And I promised myself when I got back to my family after deployment that I would introduce more balance to my schedule, take some weekends off, you know, stuff like that. And although I felt guilty doing that because I felt like whenever I left the hospital, I was abandoning my patients, I had to come to grips with being okay with that. Because I was, you know, you're running a marathon. And what I was doing is I was trying to sprint a marathon. And you can't do that. You got to pace yourself. And so, you know, I think everybody faces their own version of that story, but you individually have to recognize when you're feeling that and figure out, talk to people, you know, talk to your teammates and the people that you work with, or talk to people that have been through it before. How do I get through this? And there's a different answer to every problem set. But the number one thing, the most important thing is you individually recognizing that there's a problem. And once you do that, then you're going to be seeking a solution. You're on your way. You know, so that's the most important thing that I would emphasize, is that everybody's going to go through their version of, you know, burnout that they don't even recognize. But if somebody calls it out, you need to take a moment and pause and say, huh, am I really burned out? And then accept it and then figure out what to do from there.
Absolutely.
Mhm.
Actually, we have another question from someone who is active duty, an active duty officer applying to the DoD medical school at the moment.
Hello.
They're asking, yeah, quite convenient right now.
Yeah.
They're asking, do you have any advice for people who would like to serve in the military in the medical field, just like you did?
Yeah, but first of all, I would not do anything different. The military has provided me with experiences that I just could not have anywhere else. It was just being able to train and be in the situation that I was in. It's all serendipitous. Nobody wishes that upon anybody, but you take those opportunities when they come and make the best of it and learn from them, and try to innovate and do things differently and improve things for the next wave of providers. But with regards to a military career, I think I would highly recommend, if you have the mentality of like, I'll go with the flow. I'm open to where the military sends me. I'm open to deployments. If you have that mentality, obviously, if your prior service, active duty, you already have that mentality. But if you're okay continuing that, and it fits with your family and aligned with your family goals and whatnot, I would highly recommend the military medical pathway, just because it's, there's no other better training ground in my mind, in my opinion, than military medicine, in terms of molding you into a leader, team-oriented person, selflessness and sacrifice for the sake of each other. The patient population that you're dealing with is a very special patient population, there's pros and cons. Right now, we're going through a transformation in the DoD, where a lot of care is being outsourced to the civilian community, and so a lot of the military hospitals are sitting and they're looking around and they're like, well, we don't have any patients. What's going on? So there are a lot of folks that are discouraged at the moment because that's happening. But I can tell you, there are waves. We're very cyclic in terms of, there are periods where we have too many patients, and there are periods where patients go away or they get outsourced, we lose patients. But it's all cyclic. The patients will come back. Something will happen. We've not seen the end of war, unfortunately, and so military medicine is here to stay. And so being ready for that next wave, that next conflict, and having the opportunity to serve. And I can tell you right now that I've done 23 years of military medicine, I look back, I think back and have zero regrets. And I think very fondly of all the people that I've worked with, and I still work with, because I'm still very connected to all those folks. And in medicine, in military medicine, believe it or not, major advances occur because it's a big funding agency. There's the NIH, and then there's the DoD. Not a lot of people give any credit to the DoD, but the DoD has as much money as the NIH in terms of research funds, research dollars. And so there's a lot of innovation going on in the DoD if you just look. And all the stories that I told, these are all DoD innovations, or related innovations. And so, that's the world I grew up in. Military medicine, taking care of very sick patients, understanding that we didn't have enough tools. Well, where do we look? How do we advance medicine? How do we save the next patient that's like this? We look into DoD R&D, research and development. That's the path that I took. What do you do when you're looking for innovation? You talk to startups, you talk to companies, you talk to academia, other academics. You have these teams that you work with, and that experience has allowed me and prepared me to be able to take the leap from military medicine and academia. I was at a medical school, to a startup, essentially, and in a medical technology company. And now, I have all these opportunities that were just not there. And I guarantee you, if I had gone the regular route, I would have missed out on all those experiences that motivated innovation. So I hope that answers that question. If you have a follow-up from that individual, I'd be happy to answer.
Absolutely. There's a lot of great insight there.
Mhm.
Actually, a follow-up to a previous topic about being an autopilot, like you mentioned,
Yeah,
you're just reacting to a sad patient case.
yeah,
Is it possible to still get to know the patient
of course.
without necessarily connecting too much emotionally, or is that not a good idea?
Yeah, so you have to find your own balance there. So if you have the capacity to do so in an environment where, you're not losing yourself, I think that patient doctor, patient nurse relationship is very, very crucial. You can't really help someone unless you connect on a human level, interpersonal level, right? Because you're not going to understand it, you're not going to empathize, and so on and so forth. But there comes a point where, you know, those interactions you're giving of yourself. Okay. And so there's only so much you can give of yourself until you tap out, you dry out. You don't have more to give emotionally. And so you got to know where that is. And so when you feel yourself or sense yourself getting low on that empathy, you got to like separate yourself from that environment, do things differently if you have to be in that environment for a little while. But if you can, separate yourself, recharge, and get back so you can do your job and be the doctor that you always thought you'd be, And so through COVID, I saw a lot of this. We call it compassion fatigue. When you run, your emotional tank is empty. And sometimes your emotional tank is empty and you can't pull yourself away. So then what do? You're stuck. You just got to figure out how to deal with it. Sometimes people don't, and that's the problem. And so, I think really the key here is you're not there taking care of the patient by yourself. You're there as a member of the team in a hospital setting. And so really what I impressed and tried to impress upon like my trainees when I was the chair of medicine and chief of medicine at BAMC is like basically look after each other, because you may have like a certain level of capacity, but your co-intern or co-resident may have been depleted because they had a couple of interactions that like depleted them. You got to be on the lookout for them, and then figure out how to help each other. I think that's the only way you get through things like COVID, like the pandemic. You look after each other, and some hospitals did that better than others. Some teams and programs did that better than others. But it's something that really does it does require some paying attention to, if you know what I mean. And that's where the leader is really important. If the leader's not paying attention, people are on their own. And so, back to the military medicine question, I feel like the military medicine is like the perfect laboratory for leadership. And the reason is, as a military doctor, you're thrown into these leadership positions years before you're ready. I was like chief of medicine at the age of like 44. That'd be it'd be Doogie Howser territory, if in the civilian setting, but at the time I was a senior lieutenant colonel to be colonel. And so you're seen as this leader very early on, and you're thrown in these situations where you're caring for and responsible for 1,000 people, and you have to make it work. And so you're learning through all that. You're learning by the mistakes that you make, and it's the perfect laboratory, and you grow from that. And I think through those kinds of experiences, like the combat experiences, you sort of learn your leadership style. And at the end of the day, everybody sort of universally concludes we need to take care of each other. that's really the only way to get through this. And that's what you learn. And that's how you grow as a leader. You learn how to take care of your people. And there's something special about that. Taking care of your people has special meaning. It's not just, buying them pizza. It's really taking care of them. It's really understanding what their needs are and taking care of their needs. And then, because if you take care of them, they'll take care of the mission. Like you don't have to focus on the mission. You just need to take care of your people, because you're surrounded by professionals who are there because they're they want to be there and they want to accomplish the mission. And so if as a leader, you're taking care of them, they'll take care of the mission for you, if you know what I mean. So as a military, executive leader, your goal should just be to take care of your people. That's the bottom line.
Absolutely. I think any leader really can see that through. It really carries over to multiple frontiers.
Right.
Another thing, and I know you've touched a lot on the differences between practicing in the military setting and practicing in a civilian setting.
Yep.
But out of all those differences, the student asks, what's been the greatest difference, maybe the most distinct difference that stands out between the two settings?
There's a lot of turbulence in military medicine. What I mean by that is there's not, if you have you don't, it's very rare to have an individual be in the hospital and be a doctor in the hospital for 20 straight years. That's just very abnormal. And it's very abnormal for a division director, division chief, or chief of medicine, or all these leadership levels to have anybody in those positions more than 4 years. On average, it's more like 2 years. Okay. And so there's a lot of turbulence, and there are some good things about that. The good thing is it's a leadership laboratory. It's this rotating, revolving door of people that get put in these positions, and they learn how to take care of that hospital. The bad thing is, if you're running a Fortune 500 company, you don't change out the CEO every 2 years, do you? I mean, some companies do, and I don't know if they're that successful. But the companies that are successful are the ones that have a core group that are there with them all the way through. And so that's the con in military medicine. In civilian medicine, you have people that are in jobs forever, 20, 30. Sometimes they'll never leave. And so the good thing about that is maybe they have institutional memory, this organization grows, but then it doesn't allow for the people coming up to grow. They hit a ceiling and they got to leave. The only way for somebody to progress in their career is to leave. That's the biggest difference.
And about that, I just wanted to ask quickly. So you mentioned since military medicine, you moved on to C-STAR Medical. Are there any other colleagues that you had back in your military medicine days who've done the same? Any stories behind that?
Oh yeah. So John Holcomb is my mentor. He is I would call a fractional CEO. So he's CEO of his own company that he created. And then he was a CMO for another company. And then he's consulting for other companies, I don't know how many companies, but lots of companies. And so he's somebody I talk to, and he's also a practicing physician, and he's a very prominent trauma surgeon. And so, I consulted him when I was making this decision, and I asked him what his life was like, and he made the transition. So I looked at him and I said, wow, that's pretty cool. That's not something that we talk about in medicine. In fact, when you leave academia to go to industry, it's considered going to the dark side. Well, I don't think that's entirely true. Maybe in certain settings, but I feel like the jump that I made and a lot of the folks I've seen make are jumping from academia to sort of startup land kind of area. So this research and development type of companies where they're trying to take a technology, device, drug through the market. That space is sort of a research and development space. And so that's exciting to me. That's where I want to stay. Once a company, technology is mature, it's out on the shelf and you're selling, that's when I'm going to move on to another company where I'm going to do the same thing over and over again, you know? So that's exciting to me. And so John Holcomb is one. I know another person who went through DARPA, Jeff Ling, and then he's now CEO of On Demand Pharmaceuticals, just breakthrough company that is making drug on demand. Amazing, right? So these are very exciting things. And then I know a couple of other individuals who rose through the ranks and highest levels of leadership in medical R&D and medicine, in military medicine, who are consultants and advisors and on advisory boards. And so this is a pathway that a lot of people do take, and it's very rewarding, personally, professionally, and it's okay to say financially.
Also, for kind of the other side of people who are going through civilian training,
Yep.
how have you seen it for them from your experiences over the years? I'm sure you've had a lot of colleagues who've been in civilian residencies, civilian medical schools, with adjusting to an actual practice during their actual attendant days and being in a military medical center.
Yeah, so that's a good question. I think there are many different pathways in medicine, but at the core of it is you being a doctor. I spent pretty much 15 years after medical school learning how to be a doctor and refining and sort of optimizing my craft. That meant spending a lot of time with doing patient care and being in the hospital and doing clinical medicine. And so, I would advise folks that go through the civilian path, or it doesn't matter. I mean, military or civilian, be the best doctor you can be. And if you're enjoying that and life is good and you love what you do, keep it going, keep doing it, But let's say, I feel like I'm running on a treadmill and I'm a worker bee in a hospital and I'm just going through the motions. Don't feel like you're trapped, because you're not. There's other things that you can do. Figure out what those other things are. You can do academic medicine, or you can go into industry and be in this, but it doesn't happen overnight. And so what I usually advise folks is be open to as many of those other things as possible, and have your hands in some of those things as you grow up as a doctor. And so diversify your activities. Don't just do that one thing and be in the clinic only and not entertain doing a little research at the same time, because maybe that research takes you to a place where you work with a clinical research organization or something like that. Or maybe that leads you to academia. So, figure out how to diversify your activities. I think that's the key to burnout, is diversifying your activities. No matter how much you love whatever you're doing, if you're doing that 24/7 all the time for 30 years, I guarantee there will come a point where you're going to say, it's got to be more than this, And so, diversify your activities. There are a lot of different things that you can do with a medical degree. And so be open to those things and have conversations with others that have done other things than just be a clinical expert, which is the core of what you do. So for me, I still practice medicine. I'm still, doing my shifts at a hospital as an ICU doc, and I'm thrown in with everybody else, but that's just so I can keep my skills, after 20 years of practice, just so I can keep my skills so that if I need to later on, I can go back to it, more half time. Right now, it's just a side gig, but as long as I keep my finger in it, I can, maybe 10 years of doing this medical tech thing, maybe I want to go back to practice, but I'm keeping my option open. Let's say I just quit that and did the CMO thing 100%, I wouldn't have that option to go back. I mean, it would be very hard. So I'm just keeping my options open, and so that would be my advice. Diversify your activities. And as you grow up as a doctor or nurse, have other things that you can go to.
Absolutely.
Mm-hmm.
I think I mean, just personally as a student, I find that very, very applicable, even though I'm just early on.
Yeah.
When you're moving from one place to another, pushing yourself to areas of discomfort,
Yep.
you're guaranteed to have growth. It's either that you have the pain and growth or the
Yep.
pain of just staying still.
Agreed. 100%.
I do have, so one quick thing, I believe, I'm not sure if this is the case, but I believe you had your contact information on the last slide, right?
Yep.
Of your presentation. One student was just asking if there's any contact information that any of these great students could refer to if they have any questions for you in the
Yep.
future. So if you don't mind, if you would share that or pull it
Yeah,
up.
I'll share that real quick. Let me see here. Here you go. You see, everybody see that?
Yeah, perfect. So if anyone listening wants to just take a quick screenshot, and feel free to get in touch with Dr. Chung. I'm sure he'd be happy to answer any questions. As our next question, we've kind of noticed this common trend or occurrence of surgery, general surgery, trauma surgery, critical care in your case, these certain specialties that are associated with military medicine. Is military medicine kind of within those trends of having certain specialties, or are there specialties that people can still go to, like dermatology if they're interested, or
Of course.
those other subspecialties?
Yeah, and this is where we've had ups and downs in terms of identity in military medicine, and you know, a training program, say in general surgery or internal medicine or critical care, cannot survive in isolation. We are all interdependent. And furthermore, when the military deploys its providers, let's say on a humanitarian mission, and you're basically going on a mission on a hospital ship around South America, yes, you need your surgeons, but man, a good dermatologist is worth their weight in gold. OB-GYN worth their weight in gold. Pediatricians worth their weight in gold. I mean, everybody's really important because you're seeing pretty much everything, right? And so if you really, really look at the training offerings, residency training and fellowship training, they're all there. They're all there. And so it's possible to subspecialize and super subspecialize and pretty much everything that you would want to be specialized in, when you compare it to a civilian program. There are certain exceptions, like radiation oncology comes to mind. That's something that the military is moving away from and civilianizing that specialty. We're hiring civilians. But for the most part, the military needs every major specialty, and they will continue to train those specialties because we're all interrelated. You can't just have a program in isolation, because otherwise it won't get accredited. Like a general surgery program cannot survive without a cardiology program, a pediatric program, an OB program, a GI program. It just can't. And so, because we're so interrelated, these subspecialties will continue to exist. Yes, there are specialties that are more quote unquote military relevant. What I mean by that is when you're deployed, you're going to practice your craft. Okay. When you're a GI doc and you get deployed, guess what? You're practicing as an internist or an intensivist. You're not practicing as a GI doc. When you're a cardiologist, same thing. You're going to do some cardiology, but mainly you're there as an internist, And so that's the only thing to reconcile for as a military medicine provider. But some people like that. Some people like that variety and being challenged and being a cardiologist and being deployed and doing critical care. That's exciting, right? But if you're somebody who wants to be the best electrophysiologist in the face of the earth, and you get deployed, and for 6 months you can't do that, that's going to be irritating. Okay. So yeah, so there's some of that you have to consider, pros and cons. And I would highly advise you to seek out somebody that has had some experience as a military physician in a specialty that is not directly militarily combat related. you got to talk to somebody like that and talk to them and see what they think.
Another question we have is, we like to usually ask this questions really with every session, because there's always some way that, whether it be through shadowing, like we're doing now, virtually or in person, or an actual position, internship, for students to get more involved in this field that we talked about here. So for whether it be military medicine or innovation with C-Star Medical, are there any internships, generally opportunities that students can get involved in, to get involved, or just at least see another side of those figures?
Yeah, so that's a great question. Every military lab, okay, there are a bunch of them in the United States. If you look up MRDC, Medical Research and Development Command, that's the Army. It's really pretty much joint, but it's the Army sort of research and development lab. If you look at their website, you'll see laboratories, research laboratories all over the place. You know, Walter Reed Institute of Research, RARE, where they do infectious disease research, TBI research, they do resuscitation research, they do, you know, travel medicine, global health research. If you look at Uniformed Services University, they do a ton of research there. They have like $450 million of research funds come in annually, you know? And so whenever you see research funds coming in, that means postdocs and research internship opportunities, okay? And so whatever laboratory or military medical facility is nearby, just do a little digging. And I guarantee you, like in San Antonio, there are like 3 research labs. There's a Navy lab, there's an Army lab, there's a Air Force lab. They're all named different things, but each of them like offer internships, and they're all paid internships, you know, it's $4,000 to $8,000 a summer, you know? And so, and they're highly competitive, and you only like, they're highly competitive, but not a lot of people know about it. It's weird. It's not common knowledge. And so, but it's common knowledge to the people that are applying, because so many people are applying. So somehow they got caught wind of it. And so ask around, look at those military research facilities. I guarantee you they will have internships available. Now, startups is a little weird, different, you know, because, you know, we have 4 employees. We just hired our 5th. So can we take an intern? Technically, yeah. But like, will we be able to provide them the experience that they really, really need as an intern? Maybe, maybe not. You know, we don't have a structured internship, if you know what I mean. When we get big enough, there may be opportunities where we're hiring internships to help us execute our mission. So, you know, using us as an example, as a startup, probably not the best place to start for an internship. You want more of a mature company, but you know, it doesn't hurt to send an email to inquire, you know, among people that you meet on LinkedIn or Twitter or whatever. Hey, are there any internships? What do you advise? It's never wrong to ask questions about opportunities, because you never know. If you don't ask, you'll never know. You got to ask. And so, you know, bottom line is there are tons of opportunities out there if you just look for them. And if they don't exist, you can even create one for yourself.
That is true.
Mm-hmm.
About the application process. So just reflecting back over the years, what was that like for you at the time to apply to military medical school?
Yeah. So, you know, my story is a little bit weird in that I was of the mindset that I said I was going to apply, and I was going to apply to one school. It was Georgetown. I was going to do that HPSP thing, but I was going to go apply to one school. And if it didn't get in, it was the universe telling me that it wasn't my thing, and I was going to do my armor. I was going to go, you know, lead tank battalions. And so that was my mentality when I applied to medical school. So it was like all or nothing, but I'm going to be fine, right? So I'll leave it up to the universe. And so that's what I did. And, I'll tell you this story real quick. I applied early decision to Georgetown. It was like a September 24th or something like that deadline. And so I don't know if they still have that, but back then there was early decision. And I applied. A week later, I get a phone call. But it's not like we don't have cell phones. It's a phone down the hallway, like 100 meters away, like multiple room doorways down, way down the hallway. And there's an orderly room where there's somebody there manning the phone, answering the phone. And it was like one of those corded phones. And they answered the phone, and it was somebody from the admissions committee on Georgetown that called looking for me. I was a random cadet, right? And so I was a student in this like living, space, basically residence hall. And so they came, knocked on my door, found me and had me go all the way to the phone. It was one of those things. That's how I answered the phone. That's old school, right? And so I answer the phone, and it's, that person's still on the line, had been waiting for me for like 5 minutes. And I'm like, Miss So-and-so, yes, thank you very much for calling. How can I help you? She goes, well, I see that you applied early decision, but your scores aren't strong enough for early decision. I recommend that you have it go to, regular decision. I'm like, oh, that's disappointing, but I'll accept that. That's fine with me. And that just means I'm not going to go to med school. In my mind, I'm thinking this. And we had, we exchanged pleasantries, and I'm about to hang up. So I'm hanging up this corded phone, right? And I hear a voice right before I hit click. I hear a voice. I'm like, hello? And it's her. She's like, hey, hold on a second. And she goes, hey, I was just wondering, just, for the sake of whatever, is English your second language? And I go, well, not exactly, ma'am. It's my third language. And she goes, what? And then she goes, wait a second, because, one of the reasons my scores were so low is because my English portion was low, relatively, compared to the others. And so she goes back, she goes, hold on a second, I'll be right back. She goes and talks to somebody, I don't know who, comes back and says, we're gonna evaluate your packet for early decision. I said, thank you very much. Click. A week later, I got a letter, for an interview invitation. I went in my uniform. I interviewed. My interview was with, at that time, it was, I think it was Dr. Knox, but Dr. Knoll. He was the at that time, the Washington football team. They used to be called the Redskins. He was the doctor for them, and the internist for them, the team doctor. And so all we talked about, I was a huge football fan. So all we talked about was football, just completely out of the blue. So we're just talking about football for like 15 minutes into the interview. And then he throws out an interview question. He's like, who's your favorite player and why? And I say, well, at that time it was the 49ers had won, and it was Steve Young who was the quarterback. And so if you remember, I don't know if you're a student of like football history or whatever, but Steve Young, played behind Joe Montana, and like was basically, compared to Joe Montana as he was coming up, and he was, always second fiddle, and like had this huge, something on his back and just motivating him. But also he was very, very humble. And I just recall seeing an interview about him winning the MVP and him deflecting all the credit to his linemen. It's like, no, it's not that this MVP is not my doing. It's because my linemen protected me. And basically give them all the credit. And that was very it made a huge impression on me. And that's what I communicated to the interviewer. And, sometimes it's not like academic excellence that gets you into medical school. It's just little things you notice like that, I think, that you can tell a story about that. I feel like that got me into medical school, to be honest with you.
Oh, wow, that was a crazy story. I mean, if you had clicked that phone or closed that phone a little faster, we might have not even seen you here on virtual shadowing.
Exactly, right? Yeah, my entire trajectory would have been different.
Exactly, yeah. All right, well, in terms of, outside of just the application process, what they're actually looking for in an applicant, could you speak a little more about that whether it be now or
Yeah.
before?
Of course, of course. So here's the thing. There is a minimum bar standard for every school. Okay. And this is something that not a lot of people know. And every year changes up and down. And you know, these schools get thousands and thousands of applicants. Okay. And so there's no way every single application is being looked at and scrutinized. Okay, there's got to be a discriminator, and they have to have 800 applications, and then they got to do a cutoff, and they look at only the top 25% of those applications. Okay, and so really, you have to make that cut for each school. Okay, that cut, and that cut line is determined by a combination of your GPA, your MCAT, where you went to school. So the GPA is adjusted based on the school. There's also some element of like what major, like there's hard majors and not so hard majors, you know, that gets incorporated into it. And then your MCAT score, and then a couple of other variables, they get thrown into an equation. Every school has a different equation, right? And then they rank order highest to lowest, and they have a cut line. All right. Your goal as an applicant is to make it above that cut line. Okay, a person who is just above the cut line is probably has as equal chance of getting in as somebody deep up near the top. Of course, you have like the top 5, they'll probably get an offer, right? But this huge distance, there's this huge group of people that you're competing against, some of whom blow you out of the water in terms of MCAT score. Once you make that cut line, none of that matters. What matters is your interview, okay, and how relatable you are during that interview process and that visit, and so on and so forth. And this extends into residency as well. And so what you have to tell yourself is, if you get a GPA at your school and an MCAT score that's good enough, and the way you assess what is good enough, if you get invited to an interview, that means you've met the criteria. You're past above that line. So if you're getting interviews, it's a matter of when, not a matter of if. Okay. And at that point, you can't give up. You got to keep going. Like if you get 10 interviews and you don't get any acceptances, you got to try again that next year, because you're that close. You've made the cut, man. You got to figure out how to interview better, number one, but how to get that experience necessary to become the person that interviewer wants at that school. You see what I mean? And so it's just a matter of when at that point. If you're getting interviews, that means you've made the cut. That means you're good enough, right? So your goal should be to get to the point where your record is good enough to get an interview. And I know a lot of candidates that I've talked to over the years who couldn't make that cut, but every year, okay, they did a master's and got improved their GPA. They did research and improved their, extracurricular activities. They did scribing, and every year they're adding something else to their application packet. And in a 5-year period, they're a totally different person at year 5 than they were at year 0. You know what I mean? And so if you've got the scores, you got to keep going. Now, I advise, if you don't have your scores, if you're shooting for a 510 and you're a 450 or 460, no matter how much you study, you need to look for something else to do. But if you're close, 500, 503, I'd say you take it again. You study your, tail off and get a better score. You get a higher score next time, so that you give yourself a chance to make that cut. That's the best advice I can give you. There's a lot of variables, obviously, but every year that you apply, if you're close, and you've been given the advice that you're close, improve your standing a little bit and use that year wisely, so that the next year you're a better applicant, and do that every year. I know people that it's taken them 7-8 years to get into medical school. They didn't give up. I have a classmate in med school who was 40 when he finally got in. He was a waiter all his life, got in. Had another friend who his dad was a physician. He went to that same school and applied to that medical school 7 times. 7 times he got rejected, although he had like legacy. But he kept on applying, kept on applying, kept on applying, and then he finally got in. You know what? He's a great, whatever subspecialist he is now.
Yeah, I'm sure. Wow. Well, a lot of insight there for those listening in. One
Yep.
last question before we wrap up, and that is, we always like to usually ask this also for really any specialty. Where do you see military medicine going in the future, the next 10, 15, 20 years?
Yeah. The only thing I can predict is that, it's unpredictable. If 3 years ago, three years ago, we were all talking about like prolonged field care and large combat operations, and we're going to be in this major war with, China or Russia or whatever, nobody would have predicted that most of our military medical operations would be to combat COVID. Like that came out of nowhere, right? And so I can tell you that within the next 10 years, there's going to be something else that occurs that nobody sees coming, and everybody's going to be surprised. And we just have to be ready, and you just have to be ready for anything. And so what does that mean as a medical provider, military medical provider, or any provider? Is just, whatever profession you go into, just be the best that you can be in that profession, and work on your craft, refining your craft. Be the best surgeon that you can be the best internist that you can be the best pediatrician that you can be, whatever you decide, radiologist, and then be the best that you can be at that craft. And then when the opportunity comes and you're called upon, you're able to go on autopilot.
All right. Well, that wraps up today's great session. This was such a memorable one. Honestly, so many stories that we heard today. A lot of them that I'll be carrying on. I personally, and I'm sure many of our audience members here will be carrying on for future years. Really motivational, really inspirational, and very informative in the end. So again, thank you so much, Dr. Chung, for joining us.
Yeah, thank you, Michael, for this opportunity. I really do enjoy speaking to young folks who have a passion for medicine and healthcare. Feel free to DM me or email me. I'm happy to engage and answer questions, and even on a case-by-case basis. So I'm willing to chat with you virtually. So contact me if you need me. And thanks again for this wonderful opportunity, and congrats again on your incredible success on this platform. And obviously it's generated a lot of enthusiasm and interest, or else you wouldn't be at number 50 and going strong. So congrats to all of you.
We appreciate it. I do have a few quick reminders for our shadowers out there. So I mentioned in the beginning that we do have shadowing credit for our sessions. And to get that credit, we do have a quiz. So that quiz is 10 questions. In order to pass it, you must receive 6 or more, 60% or more on that quiz. And it's now posted in our chat box. It's also available on our website under the virtual shouting page. Just scroll a little down. We have a Monday quiz and a Thursday quiz per our Monday and Thursday schedule. So today's Monday, click on that Monday quiz for Dr. Chung, and you'll be able to be directed onto the Google form link. Again, 6 out of 10 questions in order to pass. That quiz will be sent to the inbox of the email address that you list. We recommend that you list a personal email address, whether that's Gmail, Yahoo, whatever works for you. School emails sometimes filter things out. Although, let's say you don't receive that certificate in your inbox, please check your spam folder. And even if it's not there, as always, feel free to contact us. It's going to be due next week on Sunday, October 2nd at 11:59 p.m. Central Standard Time. We usually have due dates around 6 days from our initial session date. And for our next shouting session, that's going to be later this week on this time, it's going to be Wednesday. Again, probably it's a great idea to stay tuned with us, because we do have some shifts in dates and schedules due to our speakers. So this Wednesday, 3 p.m. Central, with Dr. Tina Ho. She's a fellowship-trained facial, plastic, and reconstructive surgeon. She'll be joining us today from her practice in Greater Philadelphia. talking again about her specialty, introducing some patient cases. A very exciting time overall, I'm sure. And for those who want to follow us for more, like I mentioned at the beginning, Instagram is a great way to stay tuned with us. Just follow us there. We post our flyers. Another one is our listserv, which is an email listserv, a weekly email we send out with not only our virtual shadowing sessions, but also more opportunities about our volunteering programs, our mentorship program when they are released. So it's going to go on a semester basis, just because it is convenient for students to also work around a semester basis. So we don't always release opportunities around that, but when that time does come around for applications, you'll definitely hear about that. With that said, though, that is the end of tonight. I hope everyone enjoys the rest of their night. We thank you for having us here, Dr. Chung, and taking some time to join us today. We also thank our listeners for taking some time to join us. But we will see you later this week. Enjoy the rest of your night.